I want to talk today about what's going on with the United States healthcare system and where I think the Affordable Care Act is headed, and why things sort of are the way they are, and what we can expect in the near future. And whenever I talk about health policy or the healthcare system, I think it's useful to return to this diagram, which was first shown to me when I was a medical student by a man named William Kissick, who taught health policy to my medical school class and was one of the original writers of the Medicare Act. And he referred to everything in health policy and healthcare systems as an iron triangle, because there are three domains you always have to think about when you're talking about a healthcare system. How much does it cost? How much can people get of it? How easy is it to get it? And what's its quality? And what makes it an iron triangle is that you can improve any one, perhaps two of these areas, but it will only come at the expense of the third. I can make the system much cheaper tomorrow, but that means either that we'll be able to give out less stuff, or it will probably suffer in quality. I can make the system better. I can improve its quality, but that'll either cost money or it's going to, again, reduce access in some way. And I can make the system universal. I can improve access, get people everything that they want. But again, quality is likely to suffer, or that's going to cost money. Healthcare reform is always about trade-offs. What do you want to get, and what are you willing to give up? The problem is that this is often sold to us as some kind of silver bullet where you can get all three things at the same time. A politician will tell you that they will make the system cheaper, they will make it better, and more people will be able to get it. And that's really not possible. It just isn't. Healthcare reform is about trade-offs, and so was the Affordable Care Act. But to discuss, even before you can discuss sort of how you want to change a healthcare system, it's always important to know where we are. And of the three of these, the first one I would like to talk about is access. This is what healthcare reform and healthcare fights have been about for the last few decades. What you're looking at here is the percent of the population insured for all 31 countries in the Organization of Economic Cooperation and Development, which is a collection of most of the developed world, which got together after World War II as part of the Marshall Plan and started to donate their data together so that we could do sort of worldwide international research. It's not important that you actually can read all the different countries here. The first thing you should note is that the vast, vast, vast majority of the countries are all bunched up at the top, because nearly every developed country in the world, in some way, provides universal access to their healthcare system to all of their population. The United States is that bright red line that's very flat, because the United States, for a significant amount of time, has been hovering around 83%. With a significant number of Americans, about 50 million or so, depending upon which year you look, lacking access to health insurance for an entire year. And as you can also see, we've been flat. There have been no improvements. We've been having the same arguments and sort of the same thing going round and round and round for quite some time. There were three countries that did worse than us. Those are Chile, I think Chile, Turkey, and Mexico, and one of them was making a run in the last couple of years. But this is what healthcare reform has been about for quite some time. Why is this important? Because study after study after study shows that people who are uninsured are less likely to get primary care. They die earlier than people who have insurance. They don't get prenatal care. They have worse poor birth outcomes. And when you they suffer annual health losses of thousands of dollars each. When you push this over the tens of millions of people who are uninsured and the many, many more million who are underinsured, it also costs us a significant amount of money. That's what the Affordable Care Act was about. The Affordable Care Act was about trying to reduce the number of people who have insurance. And it will work, or it will work very much likely along the metrics that we want. How will it work? Well, it's based on three principles. The first is that everyone should be able to get health insurance, even if they have a pre-existing condition, even if they're already sick, and you shouldn't have to pay any more if you're sick. If you have diabetes and you want to get insurance, you shouldn't be penalized for it. This is a very popular principle. There's a problem with this, though. If we make a law that says that everybody should be able to buy insurance even if they're sick, then it is perfectly rational that healthy people will stop buying insurance. Because if I know that I can buy insurance when I get sick and you can't charge me more for it, then why would I want to buy insurance when I'm healthy? It's a perfectly rational economic decision not to buy insurance. To stop people from doing that, we have to create some sort of incentive to get people to buy insurance even when they're healthy, or else the system will break. And if you're going to make people buy insurance, if you're going to pass any kind of regulation or law that makes people or incentivizes people financially to buy insurance, you have to make sure that it's affordable. You have to give people subsidies in some way or some kind of money to make sure that people even in the lower end of the socioeconomic spectrum can afford it. These are the regulations, which everybody loves, the individual mandate, which everybody hates, and the subsidies, which people are somewhat divided on. But they form what we call a three-legged stool. Why? Because all three are necessary to make this work. If you want the regulations, and the regulations, by the way, are how countries worldwide provide a universal healthcare system with private insurance. That's how it's done. This wasn't some magic idea that was sort of whipped out of the air. It's how Massachusetts did it. It's how Switzerland does it. It's how Germany does it. It's how every country that builds a system on private insurance creates a universal healthcare system. It has some sort of regulations like this. But if you can't have the regulations without the mandate, you can't have the mandate without the subsidies. It's why it's a three-legged stool. If you pull any one of the legs out, the whole thing will fall over and collapse. And as I said before, it will work on the metrics that people were sort of planning it on. What you're looking at here is the number of uninsured without the law and with the law. Based upon CBO projections, you see that even back before the law was passed, they expected at some point in 2014, when the exchanges kicked in and the Medicaid expansion kicked in, that the number of uninsured would drop and would continue to drop until about 2016 or so, when things would flatten out. There will still be uninsured people in the United States. Some people will choose not to buy insurance and will pay the penalty. So be it. There will be many undocumented immigrants who will still not have access to insurance, either through the exchanges with their own money or through Medicaid. And so we will do better, but we will still have some uninsured people in the United States. And this is not far off from how it has played out. The failure of the Medicaid expansion in some states has meant that some states have higher rates of uninsurance than we thought, but other states have actually engaged things slightly better than we thought. And so the numbers have been dropping in ways that are not too far off from what was projected even before the law. But that is only one way to measure access in the United States. And there are plenty of other ways that we should care about access and plenty of other ways where we're still not doing well. I'm going to present you a number of slides where I'm going to talk about different ways of looking at access, and in all these slides I'm going to use studies from the Commonwealth Fund that have been done in the last couple of years. It's important, I want you to note, that I'm going to show you a variety of countries, because I do not want to cherry pick, because in almost every one of these slides we will beat Canada. And that is why politicians love to demonize Canada, and they love to talk about Canada, but there are lots of other industrialized nations, and we shouldn't just pick one. This is the percent of people in the United States who have to wait a week or more to see the doctor when they're sick. Almost 1 in 5 Americans, and this includes plenty of insured Americans, need to wait a week to see the doctor when they are sick. You will note we beat Canada, where more people have to wait, but there are plenty of other countries that can see doctors much faster than us. And when we talk about wait times, these things matter. These are the percent of people who have difficulty getting care on nights, weekends, or holidays. And this is a problem because a lot of life occurs on nights, weekends, or holidays. And as you can see, again, we beat Canada. But many other countries do a better job than we do, where it is much easier to get care at times when it's not sort of 9 to 5 on weekdays. This, by the way, has been shown in studies to be one of the major reasons why people overuse the emergency room. It is not because of uninsurance. Contrary to what you've heard, in fact, since the Affordable Care Act has been passed, more people have been going to the emergency room. And a lot of people are saying this means the Affordable Care Act is failing. That is not true. When you increase access, which is what the Affordable Care Act is going to do, people will use the healthcare system more, including the emergency room. The problem is when you increase the access, lots of people still can't get to see the doctor on those 9 to 5 weekdays, and they go on nights, weekends, or holidays, which is when the emergency room is open. And one of the major reasons why is because it is very hard to get care in this country on non-weekday sort of regular work hours. This is the percent of adults who are confident or very confident that they could afford care if they needed, and here we're clearly the worst. Fewer people in the United States believe that they can get care, and these are, by the way, again, include insured people. Almost half of Americans are not confident that they could afford care if they need it, which makes us much worse than almost any other country we compare ourselves to. This is the percent of adults with serious problems paying or who are unable to pay their medical bills, and in this case we look like none of the other countries. 1 in 5 Americans, again including insured people, are worried that they can't pay their bills. This is even worse. 1 in 3 Americans will avoid care because of cost. This is a lab test that is ordered that does not get done. It is a prescription that is given that is not filled. And it is a consult or a referral that is made that the people do not go to the doctor. 1 in 3 Americans will avoid care because of cost. And what I've done in this next slide is I'm breaking that last slide out by the richer half and the poorer half of each country. The richer half is in yellow and the poorer half is in green. What I want you to note here is that the richer half of America is more likely to avoid care because of cost than the poorer half of almost any other industrialized nation in the world. The richer half of America is more likely not to get a prescription filled, not to get a lab test done, and not to see a doctor that they were referred to because of cost than poor people in almost any other country we compare ourselves to. This is not a problem of uninsurance. This is a problem of cost of healthcare in the United States. So our access is not so good. We hope that it'll be better once the Affordable Care Act really kicks in and keeps going and when things get going. But as I said before, the Affordable Care Act is mostly about providing people insurance. It's not nearly as focused on the cost, and the cost remains a problem. And that's what I'd like to talk to you next about for a few minutes. What you're looking at here is a reasonably complicated diagram, but this is how the CBO, or the Congressional Budget Office, projects the budget for the future. All the areas of shading are spending. That dotted line that you see going horizontally across is revenue, it's taxes. Anytime that the dotted line is above shading, the United States is in a surplus. You can see that rarely occurs. Back in the late 90s, early 2000s, we had a surplus. But since then, the dotted line has been below the shading, which means we're in a deficit. You can also see that there was a serious bump around 2008 or so. That was the stimulus. That was when spending skyrocketed and everyone started to panic. But there's a few things that I really want you to note here. Spending can be broken down broadly into three categories. The bottom is what we call non-interest spending. That's everything the government does that's not entitlements, really. That is the FBI, that is defense, that's Homeland Security, that's schools, that's education, that's everything the government does. And while we panic about spending in this country, that's relatively flat to decreasing as a percentage of GDP. You can see where things went really high during the stimulus, but they've already come back down and they'll continue to go down in the future. The dark blue shaded area above that is Social Security. And it's very fun for politicians to demonize Social Security and talk about that as if it's going to run us into a ditch in the future. But as you can see, Social Security rises gradually as a percentage of our spending until about 2040 or so, and then it starts to decrease back down to a more manageable level. Because, of course, the baby boomers will grow as a share of payment, but then contract again in the future. But what's really important to note is that both of those, they're relatively flat. That's not a sky is falling kind of screaming thing we need to do. What's going to kill us is health care. That upper blue area of shading is Medicare, Medicaid, CHIP, and the exchange subsidies. And don't be fooled, the Affordable Care Act made that wedge bigger. Because, of course, now we made a Medicaid expansion and we paid for the subsidies. And the Affordable Care Act tries to pay for things by making payments smaller in other areas, including some of that area down at the bottom. But we do not have a spending problem in the United States long term. We have a health care problem. All of our future financial problems are almost entirely driven by healthcare, and everything else that we talk about is almost a distraction. We can make changes to Social Security. We can even make changes to spending in other areas, but they are infinitesimal almost compared to the changes that we have to make to our future healthcare spending, because that's what's going to really make us have a problem in the future. It is not just a public problem. There are four lines here. The bottom dark line there is workers' earnings, and that is for about 12 years, from 1990 to 2012. The gray line just below that is inflation. And as you can see, inflation has been very low for the last decade, and workers' earnings have barely beaten inflation. But those top two lines there, the dark line that rises way up, those are health insurance premiums in the employer-based insurance market, which have grown at a rate far, far, far faster than inflation and far, far outpaced earnings. And that yellow line, which runs along with it, is workers' contributions to those insurance premiums. And that's part of the reason wages have been flat. And one of the reasons workers are continuing to complain that they're not getting paid and they're not getting raises and the economy has been stagnant. Part of that is because all the money that we might like to dump into workers' wages keeps getting diverted into health insurance. This is private insurance, employer-based health insurance, where things have been rising far too quickly. There's a lot of people who will tell you that health information technology is the silver bullet. This is a slide I love to show from a health affairs study in 2005, which shows United States healthcare spending is that sort of light gray line at the top, projections for the future. The line right below that is the projection of if we could only achieve the 1.5% efficiency that the retail industry gets from information technology, look how healthcare spending would come down. And if we could achieve the 4% efficiencies that telecommunications gets from information technology, look how low healthcare spending would be in the future. All our problems would be solved. This was 2005. Everybody got all excited and politicians ran on the idea that health information technology would help us. They updated that study in 2013, where now the yellow line is what actually happened, and as you can see, health information technology has had almost no effect on healthcare spending whatsoever. I do almost all of my research in health information technology. I love health information technology. Health information technology will make almost no effects on how healthcare spending goes. It is sold as the silver bullet often, but this problem is not so easily solved. Moreover, we've been saying this for decades. Our healthcare spending problems are much larger than can be fixed probably with this. There are some good news. Healthcare spending is at the slowest level of increase than almost we've ever seen ever in the years that we've been tracking this. It's been rising at about 4% with the last few years. The fact that we're celebrating a 4% increase tells you how bad things were going. Granted, it's been much, much worse in the past. No one knows why. You will hear defenders of the Affordable Care Act tell you that much of the decreased spending increases is because of the Affordable Care Act. That's a little hard to swallow because, of course, many of the changes didn't go into effect until long after a lot of the slowdown started. You will hear people that don't like the Affordable Care Act say that it's due entirely to the fact that the economy has slowed down. But even as the economy has started to pick back up, healthcare spending has remained low. And so no one is sure why, but it's good news. The problem is that we have so far to go. This, again, is all 31 countries of the OECD with their private and public spending as a percentage of their, or how much they're doing total, excuse me. And as you can see, the United States is all the way on the left. Our spending is 2 to 3 times per person what any other country in the world spends. What's even more sad is that the bottom half of that line is public spending, and that is underestimated because we're including private spending, all of the private insurance that you pay for out of tax dollars. I work for a public university. Your tax dollars are buying my private insurance. That is public spending on healthcare. Public spending on healthcare is about 2/3 of healthcare spending. And 2/3 of that line means we're already spending more on public money than any other country spends in the world total. Private, public, doesn't matter how their systems run. We already have the largest funded government health insurance system in the world before we spend any money on private health insurance. Our costs are far beyond any other. I want to show you that one more way. I'm going to graph for you here healthcare spending versus GDP. So on the x-axis, you're looking at the wealth of a nation in GDP per person. On the y-axis, you're looking at healthcare spending. And if I graph pretty much every other country but ours, there is a very tight, rational relationship between how wealthy a country is and how much money it spends on healthcare. And that makes sense. Wealthier countries should spend more money on healthcare. They should. And that's what we need to remember. We should be spending more money on healthcare than any other country in the world. That is utterly rational. But at a certain point, more spending becomes less rational. The drugs don't work any better if you spend more money on them. An appendectomy doesn't have better outcomes if you spend more money on it. And so countries on the far right side, which are Norway and Luxembourg, actually start to drift below the line, where they're not spending any more money on healthcare, even though they have significantly more wealth. But the rest of the countries form a nice, tight relationship, as I said before, between how wealthy you are and how much money you spend. One country, however, is almost literally off the charts. That is the United States, which spends far more than you would expect given our wealth, and that's the key. It's not that we shouldn't spend more money than other countries on healthcare. We should. It's how much more we spend than given what you would expect given our wealth. Everything between that dot and that line is waste. Economists can't figure out what we're doing. Why are we spending it? That is tons and tons of money, hundreds of billions of dollars that is being spent in areas that don't make sense rationally. It is more than you would expect given our wealth. And that, again, is often what's driving many of the problems in spending. But back to the Iron Triangle, we now have a system which is not good in terms of access. It's probably worse than almost any other country we compare ourselves to, and our system by far is more expensive than any other country in the world. A rational healthcare system would therefore be trying to maximize the third. We would at least be able to say, if we're going to spend a fortune and limit access, our country should have by far, unequivocally, the #1 healthcare system in the world. And the fact that we can't say that for sure is a real problem. There are lots of metrics you could pick to measure the quality of a healthcare system. I could talk for hours on those, but I'm going to present some of the most common. You would hope if we have a very expensive healthcare system and we don't have a lot of access that we'd at least have a lot of doctors, but we don't. This is the doctors per population, sort of how many doctors we have per 1,000 people of the 31 countries in the OECD. And as you see, I grabbed that in red. The United States is towards the bottom. We have few doctors here. And we're spending a fortune, remember, a ton. And we're not giving it out to everybody. We don't have many doctors. And part of the problem is that our relationship of generalist to specialist is way off. The light shaded area is specialist, the dark shaded area is generalist, and as you can see, our ratio is almost all the way to the end. But here's the real problem that's hard to grasp. It's not that we have too many specialists. We actually have an average amount of specialists. Our problem is that we are woefully low on generalists. And everybody keeps talking about the fact that we need to convert our specialists to generalists, that we have too many specialists. We don't. We just have so few generalists that even with the average number of specialists we have, our ratio is just way off. And so therefore, what we really need to do is massively invest in our generalist infrastructure and stop focusing so much on trying to get people out of specialists. Try to get a specialist appointment in the United States of America today. I even have friends who are wealthy, who can't get appointments with specialists because we have still not enough. We have like an average number, and that's not enough for what we're trying to do in the United States healthcare system today. We're not training them. This is the number of medical graduates. We turn out fewer medical graduates than almost any other country in the world, which is why so many foreign medical graduates keep coming to the United States and filling up residency slots and taking residency slots, not just filling them up. We need them. We absolutely need them. We are not training enough doctors for the future here in the United States. Even given the fact that we know we have a massive doctor shortage, we can't seem to figure out a way to turn out more medical graduates to take care of people. People keep talking about preventable admissions. This is the new metric that CMS likes to use in talking about how do we do in terms of quality. We're going to measure people for readmissions and things like that. This is preventable admissions for asthma. And as you can see, we're second to last. We're beating the Slovak Republic. We don't do well in the metrics by which we would measure quality internationally. This is, let's pick, how do we do in terms of disease, prevention? How do we do? This is people dying of heart attacks, ischemic heart disease mortality. We are clearly in the bottom half. More people die in the United States of heart disease, of heart attacks, of ischemic disease mortality in this country than most of the other countries. And this, again, it's after we're spending a fortune and after we're not having access for everybody. But, life expectancy, not a perfect metric. Many people don't like life expectancy as a metric of quality. They will point out to the fact that it's related to many things outside of the control of the healthcare system, things like alcohol, even though we have lower rates of drinking than most of the OECD countries, to tobacco, even though we have lower rates of smoking than most of the other countries. They'll point out it could have something to do with demographics, even though we have a smaller percent of elderly people and a higher percent of children than almost any other OECD country. And they'll also point to obesity, where, yes, we don't do well. And we have a higher number of people with obesity than almost any other OECD country. But the important thing again here is you're looking at life expectancy versus GDP, and we're an anomaly. We are not even close to the line where every other country lies, where they have all different kinds of healthcare systems. They have private systems, public systems, single-payer systems, single-payer finance systems. It doesn't matter. They all have a reasonably decent relationship between how much money they spend on healthcare and life expectancy, and not the United States, where we're spending far more money pushing us to the right, but not achieving the same goals. And let's stop cherry picking entirely. This is a very complicated diagram which was published in JAMA about 2 years ago in a big review of quality versus other countries. What I want you to take home from this is just the colors. Red means you're doing worse than average. Yellow means you're sort of average, and green means you're better than average. And then they picked many, many disease states. And you can't see them, but these are not obscure. They're like heart disease, breast cancer, prostate cancer, stroke, diabetes. all the things you could think about. And we are green only in stroke. We are better than average in preventing years of life lost in one of the disease states that they were looking at. We are yellow in a couple, and we are red in all of the others. I encourage you to go read this paper. The United States does very poorly in trying to prevent people from dying overall as a nation in all of these disease states compared to other countries. If we cherry pick, we can find a disease and a country and a year where we will clearly win. And you will be able to find papers in the medical literature that we will say, we beat England in this disease. We beat France in this disease. We beat Canada in a number of diseases. But when you stop cherry picking and you look overall, the quality of the United States healthcare system often falls short. This should not be taken as somehow that our hospitals are of inferior quality or our doctors are inferior quality or anything else. There is no question that if I needed a heart-lung transplant, there's no place I'd rather be than the United States, and I could pick any number of hospitals where I would want to have that procedure done. We have some of the finest facilities, finest technology, finest physicians. The pieces are put together in a bad way. The system often fails in a global way when we look at sort of how things are working across. And that's the big problem looking forward. We have a healthcare system which is somewhat irrational. It costs a fortune, its access is suboptimal, and its quality is not clearly number one. And that almost by definition remains a problem. But we're still fighting old battles. We're still fighting about the Affordable Care Act and trying to just fix uninsurance. And so there have been some recent developments in that area. The first is the exchanges. You know, when the bill was written in the long ago, the first few versions put out by especially by the House, had a national exchange, one big exchange for the whole country. It was thought that this would have a number of advantages, but a lot of states, especially conservative states, fought that. They wanted health insurance to remain regulated at a local level because they felt that that was better done at the state where it has always been done. And they won. The conservative states won that battle. The Senate version was the one that finally got done. The final law had state-level exchanges. Ironically enough, the world is now flipped on its axis, and that the states that fought to have a local exchange have now let it go and let the federal government run it, and many of the states that originally had fought for a national exchange are now very excited to take a local exchange where they have added regulations, not subtracted them, to what was already going to be done at a federal level. There were many reasons to prefer a national exchange. Economy of scale. Might be easier for many insurance companies to only have to make one set of products that could be actually just given out across the entire country and not have to meet many different regulations. There was less chance for roadblocks or for any states to put up battles. But that's not how it turned out. At last count, we got about 19 state-based exchanges, 7 and about partnerships. So about half are engaged and about half have defaulted to the federal exchange. This is a problem because of a Supreme Court case that'll probably be decided in the next few weeks. Because of one clause in the law that says that subsidies will be given through an exchange established by the state, and the entire world hinges on that established by the state. Because proponents or the people bringing this law are saying that only exchanges established by the state can get subsidies. If they rule against the plaintiffs, the Supreme Court, nothing will happen. The law will keep functioning as it functions and the world will keep spinning on its axis. If, however, they rule for the plaintiffs, no one is quite sure what will happen. In a worst case scenario, for those who support the law, this will mean stripping the subsidies from all states that have a federal exchange. That means about 6 million people will lose their subsidies almost overnight. That will be a big headache for many people who are holding up this law, and another 1+ million people will probably also lose insurance because premiums could therefore become unaffordable, because that will change the dynamics of the local insurance market. If that many people drop out of their insurance, more healthy people will drop out probably, and that will mean that premiums will go up for everyone, and probably another 1+ million people will wind up losing their insurance. This will be a major headache. There are a number of ways to sort of overcome this glitch. If this is what happens, I'm sure the administration is putting together some proposals to find ways for states to quickly set up their own exchanges, which all they would do is create a body which would then hire out basically the federal government. Lots of people think that would be illegal, but this will be something that will have to happen. It's going to happen in the next few weeks. Again, it's not quite as big a deal as if they had overturned the individual mandate a couple years ago, but this is still something that everybody is watching very closely. The second area of concern is the Medicaid expansion. Everybody in the Affordable Care Act, the original way that was written, everyone earning up to 138% of the poverty line was supposed to get Medicaid. This meant about half of the 30 million people who were supposed to get insurance through the Affordable Care Act were going to get Medicaid. Some states opposed this for two reasons. One was that they assumed there'd be hidden costs, that although the federal government was going to be very generous, that at some point the federal government would default or stop paying for the Medicaid, and this would therefore fall to the states. The second is what we call the woodwork problem. The government was only being very generous with newly eligible people for Medicaid, but there are many people in the United States who qualified for Medicaid before the law was passed but had never taken it. Those people were not going to get the very generous 100% paid for by the federal government idea. They were going to have to be paid for in the usual 75-25 way that Medicaid usually happens. That will cost states a lot of money, and states were upset about this. There was a flaw in their thinking, however. Lots of people are going to come out of the woodwork and have, regardless of whether they accepted the Medicaid expansion. They can't turn those people away, and they're going to have to pay for them no matter what. So avoiding the Medicaid expansion does not necessarily take care of the woodwork problem. It's worth a quick review of what Medicaid used to be and still is in many states, because people assume Medicaid is a universal program for poor people, and it is not. Medicaid has to cover children under the age of 6 up to 133% of the poverty line, and it covers children older than that up to the poverty line. And SCHIP, or the State Children's Health Insurance Plan, covered children in most states up to 300% of the poverty line. So kids are very well covered. They have to cover pregnant women up to 133% of the poverty line. It's interesting to note that 1 in 3 children in the United States is born under Medicaid. 1 in 3 women who deliver babies do so under Medicaid, meaning that 1 in 3 women who deliver babies in the United States live in poverty. Medicaid is a huge coverage of deliveries in the United States. Medicaid has to cover parents to 1996 welfare levels, which is interesting and complicated, and it also has to cover the elderly and those with disabilities who receive social supplementary insurance. But here's what that means. What is poor in the United States? The federal poverty line for a single person in the United States is about $11,000. If you're a single mother with a child, on the other hand, it's about $15,000. This means that if you make minimum wage, and what minimum wage used to be in most places, and you did it for the entire year, you would still be just under the line for Medicaid. But Medicaid is not perfect. States can set their own rules. And in most states, in fact, pretty much all states, if you are under 65 and you don't have children under the age of 18, if you are not a parent, you cannot get Medicaid no matter how poor you are. If you make $0 a year and you have no children, you cannot get Medicaid, period. And that is most states in the United States. And the parental limit, which was 1996 welfare levels, can be shockingly low. In Arkansas, it's 16% of the poverty line, which means if you're a couple with 2 children and you make just over $3,000 a year, you are too rich for Medicaid. Medicaid is not a universal program for poor people. Medicaid is a universal program for children, pregnant women, and poor elderly people, and very few elderly parents. But for adults, even working adults in the United States, even if you have kids, it doesn't cover many, many people. Of course it doesn't. This is why half of the 30 million people were going to qualify for the Medicaid expansion, and they all made less than 138% of the poverty line. They were people without children, who were the working poor, who were making up to 138% of the poverty line, and there were many parents still, who still made limits like above the limit like this. And don't think I'm picking on Arkansas. I'm picking 10 states here to show you. That's Arkansas, Louisiana, Texas, Alabama, and West Virginia, where you can see that the percent of the poverty line that you have to make is incredibly low. If you make $5,000, $6,000 a year and you're a family with 2 kids, no Medicaid, too rich for Medicaid. Other states, however, are much more generous. California, New York, Illinois, all the way up to Minnesota there, which is very, very generous. So Medicaid was not the universal safety net for poor people, but it was going to be. But the Supreme Court decided that the Medicaid expansion was not going to be mandatory for many states, which meant that many states opted out. States that forego and have foregone the Medicaid expansion are suffering to some extent economically. In 2016, accepting states got about $30 billion from the federal government. And it's important to remember that Medicaid money isn't like cash. that you could spend on whatever you like. That is $30 billion that went directly into the healthcare system. That's $30 billion that went to hospitals, to drug companies, to device companies, to local businesses and everything. That's money which is spent on healthcare locally that keeps the healthcare system going. States that did not accept the Medicaid expansion left $35 billion on the table. And businesses around the country are letting their representatives hear that. Indiana last year decided to accept the Medicaid expansion. That was almost entirely because local business was yelling so loudly that so much money was being left on the table that the healthcare systems, the hospital systems, the many device companies that we have, pharmaceutical companies, all of them were losing significant amounts of money because the Medicaid expansion was not being accepted. Providers are still going to care for the uninsured. And studies have shown that in the states that did not accept the Medicaid expansion, the percentage of patients who are uninsured and being seen has gone up. And the percent of patients who are uninsured in the states that have accepted the Medicaid expansion has gone down. That is quite simply just, again, money going into the system and into many businesses locally that accept the Medicaid expansion. But what does this mean to you? And when I say to you, I mean various sectors. The take-home message here, the one thing, if I can get you to remember one thing as you leave here today, is that all reform, doesn't matter how conservative it is or how liberal it is, wants to spend less money. There's no politician in the United States, none, who is running on a platform of we need to increase our healthcare spending. They all want to spend less. And while everyone is panicking in the healthcare system that healthcare spending has been slowing down and we're all seeing decreased revenue and worrying about it, the rest of the country is rejoicing. And if the Affordable Care Act is repealed tomorrow, no one is going to increase healthcare spending. It's not going to happen voluntarily. Healthcare spending is growing more slowly than it's almost ever grown before. It is great for the United States of America. It is terrible for everybody that works in healthcare. We're seeing layoffs. We're seeing people worried about revenue. We're hearing many people complain. We are complaining in the bubble, but the rest of the country is looking at the future budget projections and getting a little bit excited because things look better than they ever have before. It is important to remove politics from this. Less money going in is the lens by which all things have to be looked at. This is not a Republican or a Democrat thing. Again, everybody wants to spend less money, and people are worried about how we're spending less money, whether it be a consumer-based driven reduction or whether it's a government-based driven reduction, but everybody wants to see less spending.